advanced surgery, so very impressive. But now I saw you another one, which I hope is going to get the first prize in American Academy. I want to do it here. So this is the one we prepared with Professor Ahmed and us here together.
Over the past several years, the technological advancements in cataract surgery have reached a very high level with specialized optical systems in premium intraocular lenses and highly safe surgical treatments with lasers and advanced phycoemulsification systems. Despite all of these, there are still unsatisfied patients for the following reasons. Is to refill the capsule, block lens epithelial cell migration, reduce fibrosis, and control dysphotopsia. Nature always inspires us. We developed Fixoflex, an artificial capsule to solve the problem. Fixoflex refills the capsule and provides a safe environment to fix your intraocular lens in a very stable position. Fixoflex is made of biocompatible acrylic material, the same one used for intraocular lenses. Its placement in a normal cartridge is quite simple, and the overall process does not exceed a minute till we place the device within the capsule. It is very easy to manage and rotate the device to the desired position according to the toric lens that we want to place. The injection of the intraocular lens is quite simple. We only need to place the intraocular lens below the capsule and the two loops of the intraocular lens within the periphery of Fixoflex. in order to place the intraocular lens in a specific position within the device. We have concluded an official study in 120 patients and with a follow-up from 1 year to 3 years post-operatively at the University of Alexandria. What we observe is that Fixoflex completely refills the capsule and the intraocular lens is precisely placed in the center of the device. The additional implantation time is 1 minute and 42 seconds, without any adverse events, and with quite efficient refractive stability and visual acuity over time. Formation of posterior capsular opacification is minimal without the need for anti-YAG laser capsulotomy in any of our patients. In a comparative study group with 3 years of follow-up with hydrophobic IOL from the same company without Fixoflex in the same clinical setup and from the same surgeon, the PCO grade 3 and 4 in orange exceeds the 50% incidence, whereas in the Fixoflex study group in blue, it is just below 1%. Nonetheless, in one case, and despite the fact that visual acuity was 20/20, the patient exhibited mobility problems and desired to be independent of glasses. Thus, we decided to exchange the monofocal intraocular lens in the non-dominant eye with an EDOF intraocular lens. The removal of the intraocular lens from Fixoflex is quite simple and with a quite common technique used by most surgeons. In succession, the placement of the second intraocular lens is just as simple as in the initial operation, and obviously, the intraocular lens is stabilized at the same level of the previous intraocular lens. Here you can see the position of the first intraocular lens and the distance from the posterior capsule. Surely we see here that the near 5, and this is the reason that the patient was unhappy, and the anterior chamber depth was 3.67 millimeters. 2 months post-operatively, we clearly observe that the anterior chamber depth has changed minimally, thus exactly at the same level as the initial intraocular lens, but most importantly, the near visual acuity is Jagger 1, and the patient is happy with the outcome.
So this coming to Alexandria for the first time, and I'm very happy and very proud to show you for the first time because actually going to be evaluated in the next meeting in the United States in October. I'd like to summarize again here. Up now, we have done 300 cases worldwide. You can see here several places. The Alexandria study has been finished already, but we're on the way. Much more studies here in some of these clinics. There are the studies, Austria, so can do the Japan study in Athens, where we're able to studies on for children, and the other to evaluate the PVO. So there are some scientific people around the world, they use already the fixed flex are very happy, like they were thinking of themselves before Asani. I like just to highlight it very shortly the final outcomes here. This is the Ocular clinic. As you saw with the first video, you see we don't have any change on the intraocular pressure. The iliac count was within the normal level, but we were lost about 8%, which is the normal loss in cataract surgery. So flare was within the normal level compared with the normal cataract surgeries. And then the distance acuity it was correctly close to zero with the Lockmar scale. And what you see here, what's really interesting is that the stability of the diamond in the Japanese study was much closer to zero compared with Alexandria 0.75 myopic shift. It was because of the design, so we changed the design for the Japanese study, and we have been more precise on the calculation in this case. The Alexandria study, we have finished the 12-month follow-up. This was being used for the CE mark. We expect to get the CE mark in the next 2-3 months from now. But we have up to 3 years follow-up with the majority of the patients, as you can see here. And this is the slides I was showing before about the findings. Again, we have no change on the first 12-month follow-up on the refractive outcomes. And we're going to 3 years follow-up, like this one here is the stability I showed you before. You see here that the refractive stability over the time is close to minus 0.75 diopters on the right slides, which in Japanese style was much closer to zero. But the most impressive, I think, slides of that one, which we find, we compare a group with the same clinic, with same technology files, all operated from Professor Hartman here, and you see how the different looks. On the left side, you see the eyes without the fixed flex, on the right with the fixed flex on the same patient. So I think the results are very impressive here. Thank you very much for your attention.
Thank you very much, Professor Marquez, for this very interesting book, and really very impressive idea that having an open back concept in order to diminish the classification, to increase the lens position that's not more authority lens. But what about restorative correction? I mean, it has a role, open back concept. Do you have any comment?
I exchanged with Professor Alexandria that was a Serbia call. When we try to solve the problem with the monofocal approach, form one eye and go the other eye, very often you are not very precise on biometrics.
Speaking about the concept, that's open back concept, open the way to transmission. Because there is already two lenses that are
very nice question, by the way. You know, they made the problem on all these modern areas, which are based on the flexibility of the clamps. I mean, most of these technologies today, they are related on how long the capsule still remains elastic. And there's no way. In my understanding of the biological point, always, even if you put a ring inside the capsule, you have a certain degree of fibrosis. That means the capsule is going to become still after a long time. That's why you see in FDA already about 15 companies in the past today, they try to put very for their community, however, they don't change.
Now, yes. And we are proud to have our Professor Ahmed Al-Masri who will share for this familiar study your comments here.
Actually, it's my honor to be in this project with Professor Marquez. I didn't expect very nice results, especially regarding the procedure classification. after 3 years, when you feel that as if you did the surgery just a few days ago, with a crystal clear posterior capsule, the patient is satisfied and very stable vision. This was very astonishing for me and unexpected, especially when we did the comparative study and brought the same patients with the same lens after 3 years and letting them come. All the others, they have a certain degree of PCO, which is definitely not this one. I think it would be a great breakthrough later on, mainly in the posterior capsule presentation and in the premium lens. And really, I repeat that it's my honor and pleasure to be with my dear friend, Minus, for this nice project. Thank you so much.
Thank you very much for these comments, and we thank you all. Thank you, Professor Ernst.
My patient is 26 years old male patient with history of chemical burn in his right eye 1 year ago. By examination, his visual acuity was counting finger at 40 centimeters and his cornea showing very deep corneal opacity. So our initial plan is to do right PKB. However, we tried out that and some mishaps were encountered along the way. At first, I have a question to my younger colleague. How many intraoperative complications of that surgery do you know? And then using vacuum terrifying to do partial thickness terrification of the corneal stroma, but the terrification was very superficial. So, by using a crescent knife, I deepened the terrification at the site of the proposed tunnel, as you can see, and using 27-gauge insulin syringe to initiate the tunnel, and then inserting the air cannula deep in the stroma to increase the probability of big bubble formation. Then injecting air to get a big bubble. Started emphysema and then bubble formed, but it was type 2. Type 2 bubble is a bad bubble due to fragile descent membrane. Checked intraocular pressure and it was high, so doing paracentesis to lower the intraocular pressure. And injecting small intracameral air bubble to confirm that this bubble is a big bubble and not a large bubble into the anterior chamber. Starting superficial stromectomy as usual, and for me this step is the safest step in the surgery. However, in my hands, there is barely moving of the big bubble. Fragile descent membrane, but it didn't work, so I do a very careful removal of the remaining stroma, as you can see. And thanks God the descent didn't rupture yet. So preparing the donor's graft by stripping and marking the descent membrane to be used in another DMEC surgery, as you can see in this video. Very careful washing of the viscoelastic from this fragile descent membrane. Application of the donor's try to take the stitch. This is the first suture. Completing the first suture as usual, and the other suture until we reach the sixth suture. And please give me your attention in this step. Unfortunately, the recording stopped at this stage, so I hear chamber 2 component, this ruptured descent membrane, and this is the patient's first day post-graft edema. Marked corneal and graft edema with air bubble filling the photo. Slide photo showing double anterior chamber with detached descent membrane that is confirmed by anterior segment OCT. Anterior segment OCT showing a graft edema and detached descent membrane. So the decision is to take the patient to the OR and injecting another intracameral air bubble to tamponate this ruptured descent membrane again. And this is the patient 2 days later with a clear graft attached descent membrane. That is confirmed by anterior segment OCT. Come back to cornea. So my take-home message that is considered as a too big bubble doesn't mean that end of the case, and in type 2 big bubble, this membrane is very fragile, so it needs careful manipulation. We need to do careful hysterectomy, always is needed to avoid early deroofing of the big bubble as it happened with me, and sometimes that case could be accomplished even in the presence of ruptured or perforated descent membrane, so never lose hope and never give up. Thank you.
شكرا دكتور إيمان. هو سؤال you are the surgeon from A to Z. على الزوم لو حبينا نسأله في أي حاجة. Please play his video لو تسمع.
Sending to you IOL cutting tape and forceps. Broken IOL complications and other IOL-related complications are the most dreaded complications for a cataract surgeon. A cataract surgeon has been performing techniques not only tedious but also traumatic to the endothelium. In the snare technique, snare may damage the endothelium. The twist and out technique is the most efficient technique. The surgeon has to be very swift and skilled. Crocodile scissors are also traumatic to the endothelium. These techniques invariably give us not only DM hold, SKs on post-op day 1, but also give us detached DM and loss of endothelial cells. Thus, we bring to you a revolutionary technique using our IOL cutting tip and forceps to very efficiently manage any IOL-related complication. We started by designing the blueprint of the IOL holding forceps and the IOL cutting tip. And as seen here in the video, just like any other ordinary tip, we use this with any phaco and it is tightened using the normal lock followed by putting a sleeve to prevent wound burn and other wound-related complications. This is the microscopic view of us placing the IOL cutting tip on the phaco probe. The IOL holding forceps is designed in a manner that with the help of the index finger and the thumb, one can easily insert it into the side hole and actually hold the IOL in the anterior chamber, giving support to the IOL cutting tip to easily slice through the IOL. Using the following phaco parameters as seen here in the video, we hold the IOL with our left hand, supporting it, making sure that the right hand has the phaco probe with the IOL cutting tip, and very easily it slices through, just like butter. As seen here, the IOL is beautifully cut into 3 different pieces, which will make it very easy for us to remove the IOL step by step, piece by piece. Thus, the final product is seen here in the video, where we are actually cutting the IOL in the anterior chamber, far away from the endothelium, making sure that it is cut into 3 pieces, and step by step removing each piece without damaging the endothelium. Hence, our revolutionary IOL cutting tip and IOL holding forceps have major advantages such as slant the IOL without extending the one does not need to test the IOL, hence avoiding bone stretching. No special technique is needed to master our IOL conductive. Not only this, but it is very safe for the endothelium and also the posterior capsule.
Thank you. Any questions?
Any questions from judges to Mr. Miraj? Dr. Miraj, you hear us?
Yes, absolutely.
Do you use ultrasound for cutting?
So in this phaco tip, I will tip, you have to just use power. So there are different machines, say for example, earthly, a power of 40 and no vacuum is needed for this. Whereas if you have a better machine like a Centurion, power of even 25 to 30 is enough. So ideally if you see no vacuum has to be used, only power has to be used. And the same ultrasound that we use for phaco, instead of using the phaco tip, we attach this tip which is specially designed. And as you see, using ultrasound, it cuts the IOL like a butter.
Thank you, Dr. Miraj. Third presentation will be Dr. Muhammad Sharif Ahmed. Which of which? Dr. Muhammad.
Hello everyone, good evening. I'm Muhammad Sharif, Assistant Lecturer of Ophthalmology at Hilton University. First of all, I'd like to thank everyone here, Professor Clay, panelists, and our judges for giving me a great opportunity to present this case here. Our case study today is under the name of Which of Which. Before I begin, I'd like to express my gratitude to both Dr. Magdalene and Dr. Mohammed, who were the reason behind the success and the management of such a case. Welcome to our case study. First of all, the patient visit. A female patient aged 40 years old came to us complaining of drop of vision and irritation, history of recurrent attacks, and also a vague history of trauma since 6 months. The medical history was negative, surgical history also negative. As the occult here is a micellar injection, the eye was filled with some minor capillaries with the lower cornea, anterior chamber was filled with some cells and flare, and what's very significant here is its first iris pigment over the anterior lens capsule and also over the anterior vitreous face. As I mentioned, the ciliary injections, multiple corneal nebulae, the felt AC with the cells and flare, and the dispersed iris pigments. Visual acuity assessment in this eye was 3/60, while the other eye was 100% normal. IOP measurement surprisingly was 8 mm mercury, accounting for ocular hypotony in this eye, while the other eye was normal, 16 mm mercury. Fundus examination, the right eye was totally normal macula and normal dust, while the left eye showing this surprising, amazing photo, which showed a very edematous optic nerve head, subchoroidal folds over the arcades, and plantar foveal reflex. So immediately we ordered ocular imaging and posterior segment OCT over the macula. In the right eye was normal macular scan, while the left eye showed this massive corrugation over all retinal layers, denoting hypotony maculopathy. OCT optic dusk. The right eye was totally normal, however in the left eye, because the dusk was very edematous, so the imaging was nearly impossible. We decided also to run a B-scan ultrasound, which showed over the axial and transverse scan these amazing photos. First of all, the very enlarged and edematous optic nerve head. Secondly, this vitreous floaters, and the very second choroid, and some sort of silicoidal effusion. So, what are we dealing with here? Let's take a look at our pose in our hands. First of all, we have the anterior segment and intraocular the posterior segment. First, the anterior segment, as I mentioned, the anterior uveitis, the recurrent attacks which are shown in the dispersed iris pigment or the anterior lens capsule. The intraocular pressure, the ocular hypotony, the posterior segment, first of all, the optic edema papillitis, the posterior uveitis, and finally the hypotony maculopathy. So what are we dealing with here? We do have two main categories here. First of all, the uveitis and the hypotony. But which is causing the other one? Is it uveitis causing hypotony, or it's hypotony causing uveitis? Let's go with a more common scenario, a more practical one. It's uveitis causing hypotony. As any sort of uveitis worldwide, we start loading the patient with steroids. Management, topical steroid benzodiazepine eye drops, systemic prednisone 1 milligram per kg was given for the patient, and finally even pre-operative injection, posterior subtental injection of triamcinolone acetate. Surprisingly, it's still the same food. For over than 1 month of continuous steroid treatment, the patient didn't show any slight or minor improvement, whether clinically and even in the visual acuity. So let's go with other scenario. It's hypotony causing uveitis. But what could be the cause here? What is the cause of ocular hypotony? As I mentioned, it's very important to be very meticulous in history taking. The patient back to its history. It showed a big history of trauma. So we are dealing with post-traumatic hypotony? Maybe. Let's figure it out. We decided to order UVM to show what's behind the iris. Surprisingly, it showed silly fluid effusion and this massive cycloplastic cleft, which ranged from 11:30 to 2 o'clock. So management, according to the literature for cycloplastic cleft, we have a very wide range of options. First of all, the cryotherapy, the surgical cyclopexy, and finally, which is quite new, is the diode transarterial cyclone photocoagulation. Being a non-invasive procedure, we decided to go for it. First of all, we applied the gunny lens to identify exactly the place of the cleft, then applying the diode laser probe over the area from 11:30 to 2 o'clock with a power of 1500 microwatt with a duration of 1.5 seconds, applying 30 shots of repeated application over 2 to 3 rows over the area of the cycloplastic cleft. The post-operative visit, first of all, in the first day, the visual acuity is still the same, 3/60, anteriorly and also vitritis, but IOP, finally, we can say it's 14 mm mercury. We are no longer dealing with a hypotony here. After nearly 1 week, and it's the same picture, however, the IOP was a little bit higher and development of some sort of cataract lens. After 1 month, we can see here the anterior chamber is nearly free, no more activity, no cells, no flare, and also development of peripheral anterior synechiae were 7 to 9 o'clock, and the IOP was 18 millimeter mercury. Let's take a look at what's actually behind and before and after each picture of the application of diode. First of all, the hypotony maculopathy, but after the diode application, nearly peripheral layers became normal and returned to its normal structure. It was a little bit hazy because it's associated with vitritis, but we can say it's normal. What about that, the color blindness photo? In the before picture, this massive edematous dusk, and after, it's a little bit hazy, but you can see that the dusk is nearly to its place. Okay, and what about the ultrasound? This enlarged dusk head in the axial scan is no longer present in the axial scan after the diode laser. And finally, with a photo of the UVM, this massive cycloplastic cleft. And after, we can see here there is minimal cerebroidal fluid, suprachoroidal fluid, but the cleft is completely closed, and we can see in other scans nearly closed 100%. So, finally we can say our take-home message here, it's very important to exclude these atypical conditions. It was very easy to say it's uveitis, dispersed iris pigments, anterior chamber, and the recurrent attacks. Let's start loading the patient with steroids, but it's not always this case. It's very important that if your treatment didn't show improvement, you have to reevaluate. You have to rethink and think out of the box always to exclude these serious atypical conditions. Higher consultation for different ophthalmology subspecialties is a must when dealing with such atypical cases. And finally, my take-home message for young ophthalmologists, always listen to your patients. He is actually telling you the diagnosis. Thank you.
شكرا محمد. هو الفاينل فيجوال اكتيف كان يوصل لايه؟
الفاينل فيجوال اكتيف still 3/60, but there is a cataract lens and associated with vitritis and uveitis, so we are not quite sure what will be the final. Cataract lens and uveitis and vitritis. It was very obvious, even the color fundus route in the OCT, it was very hazy. So we are not sure the visual axis is related to the uveitis vitritis cataract or it's related to the previous hypotony maculopathy. We are not sure.
شكرا محمد. Next presenter, Muhammad, Unmask the Devil. يا ريت التايمر